My dear friends and esteemed audience, I'm delighted to inform you that we have amidst us today. I consider him the greatest stalwart in the field of endocrinology, the presiding officer on professor of endocrinology at the famous PGI in Chandigarh. And he has been the professor and head for many years. And the products we see all over the country. But I'll just say two things about him: a teacher of teachers, a very brilliant career, outstanding career from the Jaipur SMS Medical College, and then culminated in the professorship and headship at the PGI Chandigarh in endocrinology, metabolism, diabetes, and 2 volumes of the endocrine rounds, which are on the Amazon. But the book speaks about his clinical knowledge. Dear friends, please welcome Dr. Anil Bhansali, and I'm going to ask him very few simple questions, and we'll kick up. And it's a friendly discussion, Anil. So we will, I will await for your answers. Very friendly, very informal. Yeah. And we have Stuti start by asking. They say diabetes is a sweet disease with sour company, and the sour company are the complications. Which are the complications you consider as the biggest hurdles to mankind in diabetes?
Okay.
Which complications?
So diabetes is a sweet disease, very rightly said, but it is fraught with so many complications. And we all know about microvascular as well as the macrovascular complications. And the microvascular complications very specific to diabetes includes particularly diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy to some extent. And macrovascular complications, we have a CAD, CVA, and PVD. If you see the trend for the complications of diabetes globally, then the Western trend shows there is a decline in diabetic complications, particularly microangiopathy complications have gone down, in fact.
What do you think the reason, Anil? What do you think the reason?
The reason for that, because the DCCT happened around 20 years earlier.
Yes, exactly.
So we have a very good message of that good diabetes control not only prevents the progression of complications, but can also prevent the onset of complications. So I think that message is inculcated into the practitioner's mind, and more focus is now on a good glycemic control, and a good glycemic control and early good glycemic control can lead to prevention of these complications.
Anil,
so you know, in the Western world, there is a trend in decline. While we don't have much data from our own country, there is no change, there is no decline in data that shows that rather there is a rising trend for complications in our country.
Yeah. Do you think that it is the complication of diabetes, is it genes versus environment? Genes, we can't do anything. How many complications you think, like DR4 in ophthalmology or ACE gene in nephropathy? Which are the complications? Which are the complications related to genes and which are purely environmental, epigenetic?
Yeah, so I think if you talk about the role of genetic factors versus the role of metabolic factors in causing complications, I think the role of there is a certain role of certain genes, like as you rightly mentioned, the ACE gene polymorphism may be associated with more diabetic nephropathy, or something may be related with the diabetic retinopathy. But I think the majority of contribution is by more the poor glycemic control or the poor metabolic control with a concurrent hypertension. And possibly some epigenetic factors might be playing a role. So I will say by 30 by 70, so 70% is in your hands by the metabolic control.
And I also feel, Anil, that in a lighter vein, you and me cannot change our parents. Not even we can change our in-laws.
Yes.
the younger people in the audience who have not chosen their in-laws can. So nothing great to talk about genes, but do whatever we can do. Anil, I know your greatest contribution. One of the greatest in the country regarding the infections and the diabetic foot. I just want to ask you 3 focused questions, then an open question. What's your message to the people to prevent the neuropathic complications and the vascular complication in the diabetic foot?
Yeah. So I think, sir, what we have seen during the last decade. So I had an interest in diabetic foot, and we are finding that the diabetic foot is in a rising trend.
Yes.
And the reason for that, if you see for that, previously the people used to die earlier mainly because of cardiovascular disease.
Yes.
The revascularization procedure has changed the scenario.
Yeah.
After that, one of the prominent disease which was killing to the patients with diabetes was CKD.
Yes.
Which has also been overcome to a certain extent by patients are getting regular dialysis or renal transplant. So now, because the diabetic complications is an outcome of increasing longevity.
Yes.
More you live longer, more you are likely to have complications. So diabetic foot is also one of the complications, which is an outcome of increasing longevity.
Yeah.
So more you live longer, more you are likely to have a diabetic foot.
Fantastic.
As far as the neuropathic foot versus vascular foot is concerned, in our country, around 2/3 of the patients are with neuropathic foot, and almost 1/3 or 20% are basically vascular, and the rest are mixed. So vascular foot is, I don't say it is riding, but it is certainly lower. And the message for prevention of a diabetic foot is that good glycemic control from beginning, that we always stress.
Yes.
In addition to that, you have to take care of your hypertension, because that is also causing a vasculopathy and contributes to vascular insufficiency. And lastly, final, always take care of your foot. You should treat your foot as a face. Like you take care of your face every day. You wash, you shave every day, you put so many cosmetics on that. So similarly, you also take care of your foot, you take care of your nails, daily examine your foot, and I think then it is a preventive.
So,
In
Anil,
addition to that, yeah.
one of your best contributions have been also in the other infections. I have just picked up 3 infections to highlight our audience. One is urosepsis, which is quite common in diabetic. I mean, what is your message you like to give? Because infection is very important. Number 2, septicemia, whatever be the cause, pneumonia, be it whatever infection, going to septicemia in a diabetic. And last but not the least, what is your comment on the antibiogram and the duration of antibiotic therapy? Does it differ between diabetic and non-diabetic?
Okay. So I think certain infections which are more predisposed in diabetic, and as rightly mentioned that we have published some data on urosepsis and particularly emphysematous pyelonephritis, we have got some data. We have also got some data on emphysematous cholecystitis and rhino-orbitocerebral mucormycosis. These are some infections which are prevalent in patients with diabetes. I think the message for these infections, because infections occurring in patients with diabetes, they usually happens in a background of a cumulative glycemic burden. A long-term poor glycemic control contributes to the your impaired B cell and T cell function, and eventually leads to more propensity for infection. I think this is preventable to a larger extent if you can control your glycemia in a normal range. So if you maintain your good glycemic control, the infections are less likely to occur. The secondly, the other diabetes like autonomic neuropathy or diabetic cystopathy, and sometimes they may develop a urethral stricture, which can also contribute to recurrent urosepsis, and particularly postmenopausal women, if they are diabetic and poorly controlled, they are also predisposed for it. So the message for preventing the infection in diabetes, I think that good glycemic control is the key. In addition, the local hygiene is also very important, that you also take care of that. And in addition, you also, because a newer class of drug like SGLT2 inhibitor, which has also come, and which has got a prevalence of around GMI and UTI is around 4 to 7% in various studies. So I think we have to also take care of what type of medications patients are taking. So we have to take care of that part. And in addition, like simple procedures like dental procedures, whenever they are performed, we should take care, because they predispose for you to rhino-orbitocerebral mucormycosis. So they should be taken in a background of a good glycemic control. I think these are some measures which can be taken. And in addition, if they have a renal insufficiency, they should avoid a fluid overload. They should avoid the metformin has to be modified accordingly. So I think if these things are taken care, so you can also prevent these infection in patients.
Anil, thank you very much. I have got few rapid fire questions. Now, how do you see the complications in the kidney and the heart? And do you advocate use of SGLT2? I don't say a person like you will say across all diabetics, but I mean, do you believe that SGLT2 can prevent cardio-renal diabetic complications?
Yes. So now I think one must understand that, as I mentioned, the people are living longer. They have tried to overcome the cardiovascular events by having a revascularization procedure. So stent, bypass has.
Yes, exactly.
After some time, you develop then the whole brunt goes to the kidney. Yes. So the next complication which is now emerging is CKD.
Yes.
Fortunately, the CKD is also taken care by many patients by dialysis or by the renal replacement. But remember, the CKD is a very important risk factor for cardiovascular disease also.
Yes. So Anil, I always tell the CKD is the fertile soil on which heart attacks cardiomyopathy, everything occurs. You are
So
absolutely
CKD, yes, exactly. The CKD is a fertile soil for the heart. So heart in a bad sense. So in a bad sense, the heart is basically more predisposed for a cardiovascular elements in presence of CKD. SGLT2 offers certain definitely advantages which we are not earlier, and which have never been also told that the patients with a low, those who had a renal glycosuria, really they had so much of benefit of that.
correct.
We only came to know after this SGLT2
Yeah.
inhibitors therapeutic trials, and which very clearly demonstrated that the beneficial effect on cardiovascular and renal outcome usually start appearing even at 8 to 12 weeks, which is too early. It is not related with atherosclerosis. It is possibly all related with the hemodynamic alterations.
Yeah. I think that's
So
true.
you have what a hemodynamic alterations which are favorable for the myocardial perfusion, similarly for the renal perfusion, and eventually leading to the improvement in a renal function, at least in terms of reduction in albuminuria reduction in albuminuria or less progression of albuminuria, you can say another way around, and even a cardiac function, there is an improvement in a cardiovascular outcome. So what
Thank
I
you.
mean to say is that this class of drug, and now they have been found to be useful even in a non-diabetic.
Yeah.
People are now trying even with a preserved ejection fraction. So far we are talking all about a reduced ejection fraction. Now people are talking even about their use in a preserved ejection fraction. So I think SGLT2 inhibitors is a class of drug which I feel now, because the cost is also coming down.
Yeah.
So
Come down.
and the Indian brands are also available.
Available.
So I think they should be the choice for the all diabetics, particularly
Very
those
brilliant.
who are having this. And
Brilliant.
I just recently reviewed one article. I think that was very interesting. Uh, if you try to control the all multi-factor risk factor intervention, which was shown in like your Swedish trial, and that showed that if you control blood pressure, if you control lipids, if you control glucose, and you take aspirin, you can prevent complications for a long, long time, and you can be rather free from complications. But and what the study showed that they use SGLT2 inhibitors and they targeted multiple risk factor interventions. If you can control by this, the additional advantage of SGLT2 inhibitor was eliminated. But what I mean to say, if you are not able to achieve all this and you add SGLT2 inhibitors, you get all the benefit what you get with the multiple risk factor.
I think that's a new
So,
thing. I think this message I'll carry to people, dear
yeah.
friends.
So,
What Professor Anil Bhansali is going to speak to us, that if you are not able to control multiple risk factors, if you give this SGLT2 inhibitor, it helps you in abating some of the risk factors. If you are able to control all the risk factors, SGLT2 may or may not have much additional benefit. But you see, we cannot control all the risk factors. So this drug has a role. Anil, from now on, I will be asking you a single sentence question, and you have to give me a single sentence answer, like an exam, because of multiple things people have asked. Number one, your comments on the legacy effect.
yes. So how do you define a legacy effect? Legacy effect is the permanent imprint of a good or a bad glycemic control on a long-term uh, vasculature or a long-term vascular complications. So that we can define that the legacy effect will be bad, legacy effect will be good, depending upon what glycemic control you are maintaining. So it's an imprint of good or bad glycemic control eventually manifesting on vascular complications. So on vascular.
What is your message to the people in 2 sentences for an
Yeah.
early aggressive control?
Yeah. So the message is that you should try to have a aggressive and early intervention. I think important is early. You have around two studies. Large studies very clearly showing one is UKPDS, which is an early and intensive intervention. And second is you have the ACCORD, you have the VADT, and you have the advanced, and you have the late intervention.
Okay.
When you start intervening late, achieving the similar hemoglobin A1C, you do very bad. And the patient usually die because by that time they already had so much of vascular complications and they are more predisposed for hypoglycemia. While if you start intervening early at a time of diagnosis, I think you succeed. It is easier to achieve hemoglobin A1C.
Yes,
You require
absolutely.
lesser number of drugs and you prevent majority of complications. I think that was a very clear message from UKPDS. So start intervening early. And I think all our guidelines now very clearly mentions you have got a time frame for even for a if you use a single drug, you have got a only time frame of 3 months. In the 3 months, if you are not able to achieve a target, you add second drug, you add third drug. And now after this verified trial, you rather than using sequential, use a combination therapy to begin with,
Absolutely.
even at a hemoglobin A1C of 7.5%.
Heat early, heat hard. Yeah.
Yeah. So the
I'll
message
come
is, yeah.
I'll come next question. I just want a very brief answer. What are your comments on the blood pressure control on diabetic complications? Number two, which are the complications which have a salutary effect when we control BP, or when BP is not controlled, those complications are more? And third, which class of antihypertensive drugs would you prefer? It's a loaded question, but for less time, I'm just asking you together.
So I think the question is very important. That the blood pressure and diabetes, they are two major outcome of the insulin resistance.
Yes.
Both are the, so what we can say that this was called as a soil hypothesis or common soil hypothesis.
Common soil hypothesis.
Where the common soil hypothesis, where the insulin resistance was the common soil, and on the top of that common soil, the two outshoots were diabetes and hypertension.
Okay.
If you talk even for a vascular complications in diabetes, the contribution of a diabetes is predominantly for a microvascular. For a macrovascular complications, the role of glucose as a vasculotoxic for a medium-sized vessels is enigmatic. Because even if you do a good glycemic control, only you find a good legacy effect after 15 years, as shown in UPD.
Okay.
So microangiopathy complications, are halted, they are prevented, their progression can be halted by the good glycemic control, but the rest of the thing does not go like the macrovascular complications.
Okay.
So hypertension becomes very important, and as I mentioned that even for all diabetic microangiopathy complications, it is not only for kidney, but even for the retinal diabetic retinopathy, the hypertension has got to do. Even for all macrovascular complications, the hypertension has got to do. So the control of blood pressure, and even you say in a diabetic kidney disease, stage 3 onwards, it is after stage 3, the blood glucose, the detrimental effect of a blood glucose becomes lesser significance as compared to hypertension. They say hypertension takes over.
Yeah.
So meaning by that, the control of blood pressure at any stage of a disease in a patient with diabetes is very important. And 50% of the patients with type 2 diabetes are hypertensive even at diagnosis, and around 90% become hypertensive with the due course of time once they develop albumin.
Thank you. Anil, we have got last 5 minutes, and I have got 10 questions. So I have only 30 seconds for your answer. Please bear with me.
The target should be,
I just want to know, targets, BP target.
The BP target, the current recommendation.
Tell the number.
Yeah, by 140 by 90 millimeter of mercury. But I think then we should try to maintain 130 by 80 millimeter.
130 and
so that should be a target. ARBs, angiotensin receptor blocker is a good choice. I think if you combine ARBs with SGLT2 inhibitors having an effect on efferent and afferent arteriole and having a direct effect on intraglomerular hypertension,
good.
I think this combination will be good. So ARBs should be used, and rather the combination of the two may be much more beneficial in preventing diabetic kidney disease. And now even the beneficial effect of SGLT2 on diabetic retinopathy, so you have an advantage of that.
Correct.
And if you do not control, that calcium channel blockers.
Yeah, I'll just touch upon only one aspect. I'll tell the name of the drug, and you tell your feeling regarding whether it's true or non-true. Now, do you think that any particular SGLT2 today has any advantage over other SGLT2 for the complication prevention between the EMPA?
Between the EMPA, CANA, and DAPA, and yes. So if you talk about cardiologists, they do segregate.
Yeah.
But what I will say, for those who have established, for a hospitalization for a heart failure, all three are equal.
Fantastic. I think I have a one sentence answer. Now the second question is what is your comments on the diabetic complication regressing after a transplant? You had been pioneering the stem cell transplant in the country, and you had, at least for 1 year, if I understand correctly, or beyond 1 year, a stem cell transplant which prevented insulin requirement and So what's your comment on the transplant and the diabetic complication regression?
Okay. So if you talk about a stem cell transplantation in patients with type 2 diabetes, where we studied around 90 patients,
Yes.
and we published the data of initial 50 patients for a period of follow-up of 1 year, there was a reduction in insulin requirement by more than 50% with
Yes.
maintaining a hemoglobin A1C below 7%.
Yes.
There was an improvement in HOMA beta and a C-peptide response to glucagon. There was a either stabilization of the diabetic complications, or rather there was a reversal of the albuminuria that we noted. However, these beneficial effects lasted only for 3 to 4 years, and after that the effect started decreasing. So their insulin requirement started going up. So meaning by that, a stem cell transplantation, this was a mononuclear cell stem cell transplantation, patients from own bone marrow, autologous. This helped us at least for a good glycemic control one. The glycemic variability was also reduced. That was one, but it was not a long lasting. It was a very short lasting effect.
Doesn't matter, Anil. I congratulate you. You have shown for the first time in India that it can be done. It can prevent. People have to follow it up, and they have to make it. I mean, the encapsulation of the stems, whatever, to make it long lasting. This is a single answer from you regarding the Charcot foot. Single answer. Screening and are we missing it?
Okay, so what I mean by a Charcot foot is a neuro-osteoarthropathy. So important is there should be presence of neuropathy, there is a presence of arthropathy, joint involvement, and in addition there is an involvement of the bones, joint bones, which you can see in initial stages by MRI by having a marrow edema on a T2 weighted images as a hyperintense lesion. And while sometimes when they come very late, they can have bone destruction. So the Charcot's neuroarthropathy may be or may not be associated with the diabetic foot ulcer. That's one should remember. One, majority of cases of Charcot foots are misdiagnosed as a cellulitis.
Yes.
So remember that whenever a patient who comes with a foot swelling, particularly unilateral, you just measure the temperature without any systemic signs. Think suspect Charcot's foot, and if it is a recent onset, the X-ray will be normal. Get an MRI foot done. That will show you the marrow edema, and the answer is good offloading for a period of 6 to 8 weeks, and along with you can use a zoledronic acid or denosumab, which can be useful for managing these patients. If you manage early, outcome is fantastic. If you are not able to manage, eventually leads to bone destruction, and eventually the foot become crippled.
Thank you very much, Anil. I have only last 2 questions. What is a specific message regarding to our physicians at large? Any specific message regarding preventing diabetic complications? And that is number 1. And last question: catching the diabetic complications early at the stage where it can be reversed.
Okay, so I think your first question and second question the answer can be summarized in one way. So whenever you see a diabetic newly diagnosed, I think they insist for a good education and insist that they should do a good glycemic control to begin with, and tell them that the importance of doing a good glycemic control at early stage can prevent the development of future complications. So this good glycemic control, sometimes even suppose someone with a higher hemoglobin A1C, never hesitate to initiate insulin. And remember, insulin even started early may not be a lifelong term, may be required for 3 to 6 months. And once you achieve a target hemoglobin A1C below 7%, you can discontinue with that. Fantastic. So the message should go that it should be early, aggressive glycemic control to begin with. Suppose you see a late diabetes, still it is always to have reap the benefit of even a late glycemic control. However, now you have to go for more individualization depending upon the number of comorbidities which the patient had. So that on basis you can decide that, but the glycemic control at any stage is good. Blood pressure control at any stage is very good. And the control of lipids, which is very easier, use of statins and use in full doses. People are using 5 milligram, people are using 10 milligram.
Exactly.
I think use 20 milligram or 40 milligram of rosuvastatin or atorvastatin respectively, and that is useful. And don't go by the numbers of the 100 or 70, go by the 50% moderate or the intensive intensity for treating for this, and add ARBs, and that is very, very useful. So take care of the intraglomerular hypertension and cardiovascular events, and now add SGLT2. So I think the diabetics are going to live longer, going to live healthier, and possibly they will maybe free of.
Anil, thank you very much. And your last message has been great. that with these drugs today, it is possible to prevent all the complete diabetic and make the diabetic live long, live longest, and full life despite diabetes. Anil, on behalf of everybody, I thank you very much